The UN Convention on the Rights of People with Disabilities requires the state to enable appropriate measures are in place to protect persons with disabilities from all forms of exploitation, violence and abuse. And that's an important obligation given the vulnerabilities involved for some groups. However, it's also a balance, I think, to be reached to avoid being too paternalistic in our attitudes. Generally, the issues that are raised in this committee is not lack of safeguards, but it's a lack of supports that prevent disabled people from living an independent life as possible. However, it makes sense that those people experiencing safeguarding issues are not potentially in a position to come before the committee. And it's very concerning that over 10,000 safeguarding concerns notified in 2020, 78% of them relate to older people and the disability sector. So my questions first for Professor Phelan for Sage. Sage Advocacy casework includes issues related to coercive control exercised by relatives over vulnerable adults, for example, people not being allowed to access or manage their social welfare payments, to people being isolated intentionally. The intersections of domestic violence and disability are not discussed enough. Can you elaborate on the issue as you understand them in this area and potential interventions which could help protect people? And you also mentioned financial abuse of vulnerable adults, and the Assisted Decision Making Act is being amended currently. We just did the PLS report in the Children's Committee, and the codes of practice are being drawn up. So I'm wondering if you could discuss changes which are necessary or measures which should be included in them. And finally, for Amanda, what could new safeguarding legislation add that cannot be achieved through better implementation and monitoring of existing laws protecting whistleblowers and requiring reporting of criminal offences against children and vulnerable adults? And then for Professor Kelly, the clarity in your opening statement, I think, was eye-opening in understanding the overlapping areas of safeguarding and mental health. I was especially struck by your articulation of how Ireland is failing to safeguard the rights of people with severe mental illness. You helpfully provided several solutions. Could you elaborate on the point around safeguarding social and medical well-being? You mentioned systematic co-working between mental health services, primary care and social care. Could you outline what that would look like in practice? You also mentioned the need for legislation that balances protection with autonomy. This is a key theme, especially in terms of the Assisted Decision Making Bill and efforts to increase community supported living. Could you discuss this type of balance and perhaps the challenges involved in that as well? And for the Irish Association of Social Workers, how can new safeguarding legislation ensure that a person's will and preference are at the centre of any safeguarding process, and that reporting cannot occur without the person's consent? And then finally, for HIQA, in your annual overview report 2022, you note that residents who live in congregated settings are at increased risk of being exposed to safeguarding issues. Could you elaborate on the types of risks and issues you've encountered and progress made by providers in addressing this? Also, the committee has heard when it comes to discussions of congregated settings, the individuals concerned and their families can often feel sidelined. Are there methods to ensure their voices are central in the safeguarding process? Thank you, Chair.
Thank you very much. So we might start with Brendan first, and then we will go to Vivian, and then to Carol and Amanda. So, Brendan.
Turning to Deputy Kearns, thank you for your questions. You spoke about the need to protect social and medical well-being. I guess some of the specific measures I've mentioned would help. I cannot overstate the need for electronic medical and social care records linked by a unique identifier number. This is possible. Our hospitals have a radiology system that is across all hospitals electronically, and everyone is identified no matter what hospital they go to. We don't have the same for medicine. We don't have the same for social care. So, for example, if someone is discharged from an inpatient psychiatry unit to a homeless hostel, there is no way of me knowing, without a great deal of telephoning, where they are 2 nights from there. And, you know, me prescribing treatments, while they're very useful and very helpful, they really are no substitute for somebody having a bed somewhere and knowing where they live. The other point, and I mentioned it earlier in terms of medical well-being, is it would be we need an expansion of the counselling and primary care scheme, where primary care practices and GPs can give people with medical cards and without medical cards, people who just don't have the medical cards, access to the counselling scheme. The balance between protection and autonomy is a very difficult one to reach. There is a tradition of paternalism. The Assisted Decision-Making Capacity Act and is I think going to help with a better balance there, and the programmes by the HSE National Office for Human Rights and Equality Policy are really focused on this. But I guess my big message here is even passing and commencing that legislation won't necessarily make this happen in practice. We need an education programme rolled out across staff so that people know the options available to them in terms of supported decision making. You know, evidence from other jurisdictions on advanced healthcare directives shows that before implementation, 90% of people say it's a good idea, but after implementation, fewer than 10% of people actually make an advanced healthcare directive. And that's all got to do with people feeling empowered, people feeling supported, and staff understanding how to make this happen. And I think my social work colleagues are nodding very vigorously at this because they play a key role in this kind of thing. Thank you.
Thank you very much. Next, and then Amanda.
A couple of people have asked the question about what will the legislation change, and I come from a background, as I said earlier on, in the criminal justice system, where many people, including myself over many years, recognise the need for much better interagency cooperation and working. And while I used to operate for many years under the unfortunate illusion that because people recognised it, that they would work really hard to change it, I think, unfortunately, the reality is that many of these problems are not really addressed unless there is legislation and unless there is a statutory basis and mandate for that type of cooperation. And I would refer back again to the example that has been cited many times about the situation in relation to child welfare and protection. And really, the changes didn't happen. They didn't happen because people knew we needed to work better in a more coordinated way. They didn't happen because of all the scandals that we had seen. They only happened when appropriate legislation was put in place. I'm not saying that legislation can answer or deal with everything, and it doesn't, but I do think it's a really fundamental foundation. Following the legislation, as was evidenced in the children's context, we do need appropriate structures and responsibility, accountability and transparency. And I'll stop there, I think.
The Assisted Decision Making Act is a huge step forward, and we're still working under the Lunacy Regulation Act from 1871. So just think about that. The wardship is 1871. It's archaic, it's not suitable. But June of this year, hopefully we will have a lot of work done in that. And I think the government needs to support the decision-making support service to fulfil that obligation to Irish people. We have the advanced healthcare planning. We also need to push out things like powers of attorney, where people can make those decisions when they have decision-making capacity. It's hugely, if we compare ourselves with the UK, it's hugely underused as a comparison to the UK. Yes, we have learned from other countries. I was led on a report with Mazars on looking at safeguarding structures in 9 different countries around the world and looking at interventions, legislation, policy, outcomes, things like that. So, you know, you can look at what, say, the Office of the Public Advocate does in Australia. You can look at what happens in Canada. I wouldn't particularly look at what's happening in Norway because they don't have any structures in responding. Japan has quite an interesting response where the police are quite involved in terms of safeguarding. But we can learn from these structures. And the Care Act, what we need to focus, the Care Act is founded on the principle of well-being. And then there are various principles in terms of safeguarding that are usually generic in a lot of the policies like autonomy, self-determination, things like that. So there are templates out there. We just need to look and say, what is suitable for our structure? How will we put it into a process that gets us the outcome that we want and desire? Thank you.
Where there is a process for moving people transitioning people from congregated settings. But in the interim, it is about, I suppose, maximising the safety of people that currently live there. The cultural questions, actually, that's what struck me when the questions were being asked. We have engaged with a lot of providers over a period of time, and we have seen changes in not just in terms of reducing the incidence of safeguarding issues, but also in terms of promoting rights of people and quality of life of people. And I gave some examples earlier on. But one of the interesting things is where you engage with a situation such as a congregated setting, and usually the main cultural issue there is that there is institutionalised care practices. So people work in those centres, have a certain perspective on what their job is and how they should do it. People who live in those centres, they get their food from a centralised kitchen. Their clothes are washed in a centralised laundry. They have no sense of engagement or control over their day-to-day living. We challenge that in our inspections. We try and maximise within that current environment how people can be promoted in terms of engaging with their own self-care and what we have found where so for example in some centres providers have installed kitchens in their units and involved residents more in the preparation of their day-to-day meals, and you can see a difference for people even in that small exercise of that action. But what's really interesting is where staff begin to see the impact of that action, and staff start to take some pride in what's being delivered and the changes that are happening and the enhancement of what's happening. So culture is really important. I agree with the previous speakers in terms of the role of legislation in that culture. I mentioned earlier on when we started the kind of situations we were seeing, particularly in congregated settings. We've challenged that. We have cancelled the registration of some congregated settings. We have required providers to implement improvements across all of those congregated settings, but that has driven cultural change, and we have seen where staff change their approach to practice and the way they approach support to residents. The difficulty, though, is that what we also see is that in congregated settings, that over time there can be a revert back to previous practices, and there's a very high risk of that. The other piece referred to by Professor Kelly earlier on is that whole piece of people who do move out from congregated settings and move to community-based settings, and the practices follow them. So it's the same, it's institutionalised practice in a small home in the community. And again, that's something we will and we do challenge in terms of our engagement. And again, it's interesting, like for example, one organisation that we we've registered their centres and we monitor their services, where they moved a large number of people to community settings. And what we have found is we're now challenging that organisation in terms of institutionalised care practices within the community settings, but actually they've made very good progress in terms of improving the rights of residents within the remaining residents within the congregated setting. So culture is key to all of that piece.